The session today is entitled Building Public Trust in Times of Crisis, the Case for Health Promotion Policy, Practice and Research, and is hosted by the NARO. The second sub-plenary will be hosted tomorrow by the Global Working Group on Health Literacy. So my name is Mathieu Roy. Okay, great, it works. And I will be the co-moderator of this sub-plenary. I'm currently a scientific advisor at the Quebec National Institute on Public Health, and I'm also working as a co-scientific advisor for the National Public Health Director right now in the response to the COVID-19 pandemic. I'm also associate professor at the University of Sherbrooke, and I'm affiliated with the Global Working Group on Salutogenesis with the NARO and with the RIFIPS on behalf of the IUHPE. My work today will be to take care of the chat, to move the slides. If there are any questions for our panelists or our main moderator, which I will introduce in a few seconds, I will manage to transfer them. And I will be also able to directly answer to some of you if it is needed in the chat, but we are also supported by someone if there is any technical issues. So now, welcome to our main moderator, the one and only one, David McQueen. I think everyone knows who is Dr. McQueen. Dr. McQueen is based in Atlanta. He is retired from the CDC now, but he was an associate director for global health promotion there. He held many professorships, in various universities. He was vice president and president of the IUHPE, and he worked as a consultant for many huge and world-renowned organizations. So thank you very much, Dr. McQueen. The floor is now yours. Thank you.
Okay, thank you very much. It's very good to be here at an IUHPE meeting, even though I'm not physically in Montreal, but it's very interesting. I've been following some of the sessions this morning, and it's quite an interesting approach. Anyway, I use interesting too many times, perhaps. The old Chinese proverb, may you live in interesting times, and this is certainly one of them. A lot of these interesting times are not very friendly or not very nice, and we're not too happy with them. But the challenges of this time are many: retreating globalization, rising nationalism, war, pandemics, racism, loss of trust in government, in science. And all of these things present really terrific challenges for health promotion. And what are the health promotion policies, research and practice that can address these challenges? Particularly, what can restore trust? That's part of what this plenary is trying to deal with. What does the field of health promotion really offer to create trust? Next slide. Anyway, I'm waiting for the next slide.
It was the next line on my screen. So
session objectives. Yes, that's it. Sorry, go back. That's it. The session objectives are to define public trust issues and challenges that need to be addressed, particularly during public health crises, and to highlight the integral role of gaining trust through health promotion policy and practice, and to emphasize the boundaries that need to be crossed for a systems approach to gaining and maintaining public trust at all levels. These objectives, of course, are laudable and highly challengeable. And and very challenging. And I think that we'll get through some of them today and in the next, perhaps the next half session, but it's a difficult area. Trust, for example, is an area that I've been interested in some time, but trust is a complex word in itself. Trust as a subject of social science research is viewed as a conceptual social construct that involves complexity. At least that's the way I formulated trust when I thought about it, particularly from reading the work of Luhmann. Luhmann was a German sociologist who wrote the fundamental book really on trust and power in 1979. It's the classic work in German, Vertrauen, ein Mechanismus der Reduktion sozialer Komplexität. And what is interesting about it is that it has recently been translated into English, and I must say, for those of you who don't read German, and perhaps even for those who do read German, the English translation is a lot clearer and more understandable. But sociology was always then involved with the idea of power and its relationship to trust. And it's an important emerging concept in postmodern thinking, particularly in health promotion. Trust is complex. It's linked to human relationships with complex technologies, for example. The pandemic is a good example of that. Trust in the pandemic has brought up a lot of issues. So a current challenge for health promotion is assessing how technology has impacted ideas such as trusts. As a side note of interest, I just point this out. I've been reading some literature on this more recently. There was recently a meta-analysis of 87 studies that showed a consistent, though modest, negative relationship between ethnic diversity and social trust. An interesting finding, and just part of the complexity we're talking about. Now we have 4 panelists today to work on this complex problem. And Stephanie Leach from Trinidad and Tobago, who's a community organizer, public health student, feminist, a nonprofit leader. She'll be the first one to talk. Then we have David Martin Milot from Canada, who's a medical advisor at Sherbrooke and in Quebec, and a professor and researcher. Joining us from the other continents on the other side of the Atlantic, Oliver Mweemba in Zambia, who we thank very much for getting up at 6 in the morning or whatever time it is there, and sounds early to me. And finally, also a colleague of mine here in Atlanta, Bill Potts-Datema, who will talk about his experience at the U.S. Centers for Disease Control. So we will start with Stephanie Leach, and here's a little bit more detail on her. You can see and read this. Her activism focuses a lot on gender-based violence, sexual and reproductive health and rights, and social policy development. So you can see that she's right in the center of the whole issue of trust, particularly with these particular kinds of groups. So at any rate, she has an academic background in gender development and communication studies, and currently pursuing a master's of public health at the University of Suffolk. So we turn it over now to Stephanie.
You're muted, Stephanie.
Hi, everyone. Good morning, good afternoon, good evening, whichever part of the world you find yourself. I am going to start now, right? So last August, my NARO colleagues and I wrote the paper, Black Lives Matter in Health Promotion, Moving from Unspoken to Outspoken, where we explored various aspects of health promotion in the COVID-19 pandemic but specifically how Black communities around the globe were disproportionately affected. For many Black people, there was the double threat of the pandemic and increased police violence in response to BLM protests that began cropping up around the world in the wake of the murder of George Floyd. 4 months into the pandemic, in June 2020, it was the extrajudicial murder of the Mweemba 3 in Trinidad and Tobago, that's where I'm from, that sparked an historic 3-day protest. For the people, it marked an important resistance to the authorities who actively pursued their one-shot, one-kill policy when policing poor communities. For the state, it marked the breaching of their public health ordinance, which was an authoritarian approach to managing an unfamiliar public health crisis. During these protests, police used extreme force, tear gas, arrests, and even killed a mother of 5 with a stray bullet, whose last words caught on video were, "Police, don't shoot." Her name was Ornella Graves. In the aftermath of these protests, police continued to raid bars and other establishments frequented by poor Black people to make arrests, while affluent citizens flouted lockdown measures by making videos of themselves lounging on private beaches. Arrests, coupled with heavy fines, were disproportionately wielded against certain communities, which only helped to reinforce widely held beliefs about the police and government, including that public trust is not meant for poor people. At the national level, there seemed to be an over-reliance on national security systems to regulate behavior, and conversely, little emphasis on using public health or other mechanisms to address social aspects of the pandemic. Can we move to the next slide? This has shown up most notably in the widespread vaccine hesitancy, considering that the rate of vaccination has steadily held at 50.9 for the past several months. A 2020 survey conducted by Johns Hopkins Center for Communications Programs reported that 59% of persons living in Trinidad and Tobago would not accept a COVID-19 vaccine if it were made available to them. The Caribbean Public Health Agency, CARPHA, also commissioned a COVID-19 vaccine acceptance study among active social media users in the Caribbean. This cross-sectional study was conducted among active social media users aged 18 years or older and older in 18 years and older up to the age of 26, with just 6 territories achieving the target sample size, including Trinidad and Tobago. Notably, a higher percentage of healthcare workers were vaccinated compared to non-healthcare workers, 64.4% versus 49.2%. And of the number of healthcare workers that were not vaccinated, vaccine non-acceptance was 22.5% and undecided was 36.9%. So we see high percentage of non-vaccination and acceptance of vaccination even among healthcare workers. Further, the percentage of participants who reported that they would vaccinate their elderly parents was higher than those who reported that they would vaccinate their children, 53% versus 38%. The effects of which are being felt now that schools have reopened, with concerning rates of infection among teachers and students. The top concern reported by participants was around the possible side effects of the vaccine, followed by not knowing enough about the vaccine as the second highest. These statistics very clearly show a disconnect in perspectives of the state and the people. First, it demonstrates the inability of the state to effectively communicate the value of this activity. This is also likely tied to the chasm between what the state regards as the accurate and trustworthy science of vaccines versus what people see as the duplicitous nature of state and corporate actors involved in vaccine preparation and distribution. The information that is available is therefore either failing to reach its intended audience that is members of the public, and or failing to sufficiently address issues of trust and sway the opinions of half the recorded population. Second, and relatedly, these statistics demonstrate the comprehensive lack of trust in the benevolence of state actors and the disbelief that they are implicitly inclined to act in the best interest of people. This is also likely related to a long-standing sentiment of distrust, as revealed by IDB reports on the topic. In fact, one statistic from a 2018 IDB study revealed that interpersonal trust in the LAC region was as alarmingly low as 14%, a situation that the IDB vice president for countries described as a crisis of trust. Now, during the pandemic, this crisis of trust has reared its head in the form of unrelenting vaccine hesitancy. Interestingly, unlike targeted violence, membership in particular social strata does not seem to reduce resistance and hesitancy to state interventions. Not only has vaccine hesitancy remained an issue even among affluent members of society, so too has the issue of resistance against safe zones and the virtual learning environments among students. Among the social elite, safe zones have been ironically referred to as a form of apartheid among those least exposed to social exclusion. In this regard, resistance against public health measures as a whole has become one of the most glaring examples of public distrust, irrespective of social standing. Can we move to the next slide, please? As health promoters, we can no longer work under the assumption that simply sharing accurate and relevant information with the public is enough. In order for communication to have its desired effect, it needs to be a two-way street. With respect to health communication, this requirement is particularly important because of the complex nature of the information being shared. To address this, relevant state actors and agencies should implement coordinated and robust communication strategies, which can include social behavior communication change that incorporates mass media and interpersonal strategies, utilizing clinics, schools, and hospitals as centers for outreach. However, this is still only one part of a bigger picture and problem. The work to address public distrust in the health sector extends to addressing public distrust as a whole. This begins with the state taking accountability for the ways in which it has failed to develop genuine and fruitful relationships with the people, starting with evaluating its strategies for encouraging compliance, both generally and specifically in relation to public health measures. Because when the state relies on the use of force and outright violence as its go-to methods for behavior modification, it communicates its implicit distrust in its people, which is then returned through resistance. The state must therefore assess the impact of the strategies it has traditionally employed to gain public cooperation, assess how these have affected public trust, and improve its relationship with its constituents. The management of public health cannot be seen as a militaristic exercise, but as an opportunity to invest in the health and well-being of local populations, with emphasis on non-violent and non-coercive interventions. I'll stop there. Thank you.
Thank you very much, Stephanie. We now turn to David Martin Milot, who is a medical specialist in public health at Sherbrooke, and is going to talk to us about some of the issues involved in the situation in the Quebec region. So David, why don't you go ahead?
Yeah, thank you, Professor McQueen. So yeah, I'm gonna talk to you about the organizational and the political context that may affect trust. And you'll see also how some partners are very good allies to work on health promotion, especially community organizations. I'm also the president of an organization called Médecins du Monde Canada, so I had a chance to see both sides of how COVID and the structure in which we were and still are affect the relationships and the trust that that exists between different people and different groups. So I'll tell you a bit about before COVID-19 crisis, during and after, or maybe not after, but during, but a bit later maybe, in terms of context, and then in terms of how it affects trust. So first, if you don't know the context of Quebec, so before the COVID-19 crisis, the population knew little about public health institutions and their role in health promotion. How it works in Quebec is that we have regional centers of public health in each of the 18 regions of Quebec. And that's where you have the expertise for those different regions. And there is health promotion teams in those public health centers. And we are in like a second line, and then the first line is community organizers and health promoters also. Community organizers work with citizens mostly on their needs that are expressed and when they want to come together to answer those needs in terms of health. And health promoters work with municipalities mostly. So we have a first line on the field, let's say, but we also have a second line that work in the health promotion. What happened is that public health institutions were very little known before the crisis, and the community organizations were at the heart of health promotion with the support of us as institutions. And they are more vocal, those community organizations. They do work that may be a bit more concrete, let's say, to the eyes of the population. But and that's why most of the people, when they think about social determinants of health, they will think more about all of those organizations that are close to them, because we have a very, very strong network of community organizations in Quebec. But unfortunately, also in Quebec, we have been underfunded in public health for many, many years. And in 2015, the government that was in place cut a third of the budget in public health, and we were already a province that was investing the least in Canada in terms of percentage of the whole health budget. We had the smallest percentage in public health compared to other provinces, and with those cuts, we were even below. And within public health, health promotion was also underfunded. But we have, just before COVID, we had a very good policy that was voted by the previous government. It's called the Politique Gouvernementale de Prévention en Santé, which brings together many, many ministries and give them targets to reach to have a better prevention in health. And that prevention is in early development, in building safer communities, in having better life conditions, but also bringing preventive measures in the health system. So we had that very good and strong background in terms of policy, but we were underfunded. And we had a new party that was elected at the head of our provincial government in 2018. And at that point, the Prime Minister said that it was the first time that he would see or meet or know of the national public health officer. So that gives you an idea of how it was before COVID. So what's the relationship with trust? Well, mainly the trust with regards to health promotion was in community organizations, which were close to the population and its preoccupations. And the relationship between the community organizations and the public health institutions was quite variable, depending on the experience that each of one had working together. But the population was not aware of the existence of public health institutions, and even less of its role in health promotion. So during COVID-19 crisis, that's when that's when I didn't have to explain to my friends what I was doing in my real life. Basically, everyone knew what public health was about, but for its protection functions. Health promotion was still little known, or at least our function as health promoters was still little known. But during the crisis, the community organizations were considered essential services. They remained active, open, their services were still on, but they faced important challenges related to COVID-19 because of the measures that were imposed by the government and not always very well adapted. So it was our role as regional public health officers to adapt those measures to different contexts. But also there was a workforce crisis, and with some of the employees that were contaminated with COVID, some of the essential community organizations had to close, at least for a few days, and it was very hard to maintain the essential services to the population for its basic needs, but also in terms of determinants of health. And unfortunately, there was a total disappearance of health promotion support by the public health institutions at the regional level because all of the health promotion professionals were affected to protection and to response to COVID, basically. What happened with trust in health promotion during the COVID-19 crisis? Actually, the social inequities were brought to light by different organizations, by different research centers, or some regional centers that had more resources who could still at least do some research on those health inequities and some surveillance to try to assess them, or at least to sensitize the population on them. And so because of that, the community organizations were mobilized to fight social inequities. Like the Canadian Red Cross was very active. There was also a group of foundations that came together and that offered their help, basically, outside their usual mission, but it was very helpful to help. It was very helpful, for example, for the people in quarantine that had special needs, or they help also with the vaccine. And also some local community organizations were quite active to fight social inequities. But there was still a disconnect between community organizations and public health institutions. We were, as public health institutions, in a very top-down fashion, while community organizations tried to put those social inequities up front for us to assess them, but we were resourceless, unfortunately, at that point to help them in this matter. So the population was aware of the existence of public health institutions, but there was a perception of dependence of the public health institutions to the government. Maybe one of the many reasons for that was that, as you can see on the right, we see at that time, it was our national public health director, Horacio Arruda, on the left, with our prime minister in the center, and all of the press conferences that were made would bring together Dr. Arruda with our Prime Minister and also the Minister of Health. And when there was a good move in terms of prevention, for example, for COVID, it was the government's announcement. But when it was a bad move, sometimes you would say, well, it's public health that asks us to do this. So that brought, that's why I wrote here that public health was used as a facade by the government. That brought some mistrust by the population, and also mistrust by public health practitioners who saw this as a show and who wouldn't recognize themselves in the decisions that were made by the provincial government. So towards the COVID-19 endemic, that's maybe where we are at now. So public health is now well known as an institution. People know that we have functions of protection in terms of infectious diseases, but that's pretty much it. The health promotion functions are still not very well known. We try to work on that. We try to be a bit more visible, especially now that we are thinking about the refoundation of our health system. We really want to keep the gains that we had during the pandemic. The community organizations, they still play an active role in health promotion. They had during the COVID active phases, good and not so good experiences with public health, public centers or regional centers that affected the relationship that they had with us. So the trust is still maybe variable between the community organizations and the regional public health departments. and also within the public health teams, between the first line and the second line, for example, the first line being much closer to the community organizations sometimes than to the regional departments. But at the same time, we have a very good window of opportunity to do some effective advocacy for better funding of public health and health promotion. And there's going to be elections also in a few months in 2022. So that's why we try to really show how important it is to better fund public health services, but also community organizations. There was massive investment by the provincial government in public health, especially in mental health, which is very good. It brought some temporary disorganization because it's lots and lots of new people that we have to train, and who came all together within our organizations. So we need to rebuild trust also within public health services. So now the trust in health promotion is mostly non-institutional still. It's maintained mostly thanks to community organizations who are still doing a very good work to assess those and address also those social determinants of health. But we need to rebuild and reinforce trust between community organizations and public health. We need to change our ways of doing things or working together. And it's still a challenge to make the population knowledgeable of public health institutions' role in health promotion. We are trying to find ways to better communicate what we do in terms of social inequities, fighting social inequities, and health promotion also. And we need though to rebuild trust between public health institution and the government. So as I told you, the refoundation of the health system in Quebec, which is one of the main projects of the actual government, will provide good levers for this. So knowing all of this, how can we use health promotion strategies to build, regain, and foster trust to enable better responses to future crises? Some of them we are already in them, and some others are to come for sure. So we should continue advocating for the recognition of health promotion as an essential service provided by community organizations and public health institutions. We are partners, and community organizations are key players, key actors to address social determinants of health. So they should be better funded, and we should find ways to better work together. We need also to better position health promotion within our public health entities. Health promotion should be considered an essential service, such as protection functions of public health. So we don't just bring all of the people from health promotion services to protective functions in times of crisis. We still need those people to work on health promotion. We need to do good health promotion also. We need to do our proof of concept and show that we can do it in a good way. In a way that is adapted to the population's needs. And also we need to strengthen the relationships between community organizations and public health institutions, as I told you already, and advocate for an independent role of a public health national director, because now that person has a double role. That person is an employee of the government, but at the same time, that person is the protector of the population in terms of health. So there needs to be independence in the roles of that person who is the chief of national of public health services. And that person needs to understand health promotion and the importance of having it very active, alive, and well funded. So thank you.
Thank you very much, David Martin. It's a very interesting presentation. I'm sure it will bring up lots of questions from the viewers. And now we move to across the Atlantic to Africa, to Dr. Oliver Mweemba, who is the head of the Department of Health Promotion at the School of Public Health at the University of Zambia. Has a lot of research experience in applying social behavioral methods to complex public health promotion, and healthcare interventions in Africa. Certainly a real challenge, and we look forward to his comments. Take it away. Thank you.
Thank you, David. So yeah, so I'm going to talk about the work we did in Zambia with the support of the International Union for Health Promotion project, where we actually focused on strengthening the capacity in schools. But basically, the whole idea is to actually relate it to how when you actually work with community structures in the context of schools, actually how trust issues actually really come up. Yeah, so basically, as you know, in terms of background, so in Zambia, we have been having a lot of cases of COVID right now. Actually, we are beginning the 5th wave, so we have not been exempted from that. And of course, like in other parts of the world, schools were closed at some point, and children had to spend long months actually at home. So what we actually, at that time, we were actually trying to work on the concept with IUHPE on how we can actually strengthen the community component to actually support centralized responses from government. So at that time, there was talk of opening schools where we actually needed to actually really support how those schools can actually really respond to the epidemic. So we actually really, based on that, we actually came up with a proposal to actually strengthen the community, like the communities around schools as well as in schools, to actually deal with some of those challenges and strengthen the response. So with the funding we got, we actually managed to give each school about basically that's $400 startup to actually really implement the community action plan. Yeah, next slide. Yeah, so the time we were working there, the context in terms of misinformation and public trust issues actually were massive. There were quite a lot of things, and people never believed that COVID-19 was actually real, and people thought, well, children cannot get or at least die from COVID-19. There was also a widespread thought that Africans cannot actually be affected or die of COVID-19. Of course, there are even some conspiracy theories that COVID-19 was created in the lab to eliminate Africans, and there are some stories that actually COVID-19 was a money-making venture by powerful pharmaceutical companies. And then also there are also this mistrust of politicians who actually they thought they used COVID-19 and maybe really spoke a bit more about it to gain funds. So what we needed to do was we needed to actually really engage and build trust in these communities. So the approach we used was to actually really engage key stakeholders. So of course, the process involved really, because it was a national research, so we needed to get review from the University of Zambia, the Medical Research Ethics Committee and the National Health Research Ethics Committee. But we also created an advisory board through the Ministries of General Education and Ministry of Health. And through those, we actually really created structures through the Office of the District Commissioners and the district education officers and health at the sites, that is at the districts, to actually really engage and work with them. So through that, we actually really worked with the local health and education departments in each of those districts. And there's a structure which has been there actually from independence in Zambia in the 1960s, where the parents and teachers have an association, a structure which actually really implements community and this educational interest. So we worked with the PTA in each school, and what we did was we engaged in participatory needs assessment, where we actually really identified the areas we needed to act. We didn't have a lot of money, but we needed to actually prioritize, and also did some participatory action planning development together, and also did participatory monitoring of those activities, and even dissemination and lessons learned. Next slide. So if you see, those are some of the activities that actually happen. Like you can see on the left, there's some teachers actually. One of them is a drama teacher. They were able to actually really do some drama, and actually they printed out some teachers to do some community sensation around the schools. And also you can see some pupils down on my left who are actually doing some performances through dance and music to actually really sensitize. And also you can actually see, despite the difficulties, like this is a community school, these are girls, no desks, but actually you could still see how they try to create space and actually maintain physical distances. So as some of the activities that actually engage them. Next slide. Yeah, so part of the projects actually we worked with, so we were able to, like, in one of the community schools, there was no water, it was a big challenge. So there was no way we were going to push agendas for hand washing and all that. So we actually repaired a borehole and a hand pump. We also created a toilet in one of the places. Actually, like, particularly the challenge with the girls was actually realized. And you can actually see some of the toilets on my right, both up and down. And then on the left, you can actually see some of the signs that actually teachers put in the communities and surrounding communities, COVID, and also the need to distance, to actually engage in physical distance. Next slide. Next. Yeah, so here basically we are actually looking at some of there were no materials that were published at that particular time, at least in the communities we worked in. So based on the lessons we learned, we worked with communities. Yeah, so we worked with communities to come up with even some IEC materials that actually were led by pupils. So I think what we actually learned is that there are certain, well, it's okay, you can move to the next slide.
This one?
So I think yes, yeah. So I think what we learned is that we needed actually really to cross certain boundaries to actually engage in a systems approach to gain and maintain public trust at all levels. So what you actually see at interministerial level, where we actually had advisory boards from Ministry and General Education, it was actually very, very useful to actually engage in that. Yeah, so in terms of lessons learned, so what you actually see is the central pillars of health promotion, which are participation, intersectional partnership, and locally driven, more or less like led programs, are relevant in responding to the crisis and actually gaining trust. And a number of activities have been implemented based on community-driven action plans, which actually also develop sensitization to provide information to the communities to dispel some of the issues and mistrust. And there was a general response from the pupils, teachers, and community members working together with also other departments at district level. And they, of course, given the times that we were working with at that time, so there was still some resistance in some communities and skepticism, especially when the vaccines started coming on board. So I think what we still need to continue doing all this work, but I think also we thought it was important to include village admin in community outreaches, which actually was very vital. Thank you. Yeah, so I think here is just actually really to also emphasize that the participatory methods of working with communities and the really engaging capacity building oriented kind of like approaches makes it effective to actually come up with action plans that are led by communities and actually develop trust in them. So I think what we saw that active participation and cooperation with communities, community members at that local, it builds trust and implementation of COVID-19 health communication and prevention program.
Thank you very much, Oliver. That's a very interesting discussion possibility from that. I would like to now turn across town to Bill Potts-Datema, who will talk about background related to this from the standpoint of his work at CDC and his concern with adolescent and school health, where he's been very active over the years. So Bill, you want to go ahead?
Sure. Thank you, Dr. McQueen. It's a great pleasure to be with everyone through this conference. And I have a long history with IUHPE and was former regional vice president of NARO. And it's just always a joy to be with everybody at one of the global conferences. So thank you for joining us wherever you are. I wanted to share that, while you see my bio, and I'm, while I worked at CDC for many years, I retired from CDC 3 years ago. And since then, I've been serving on a number of national boards in public health and education, and doing other activities as well in the profession. And I wanted to mention that the comments that I'm going to share with you are all my own, and they're from my own experience. and primarily from my experience in the past 3 years after retiring from CDC. I will talk quite a bit about the politics of this issue. I've been very active in the political side since leaving CDC. I was on one of the health policy and education policy committees for the Biden campaign nationally. And I also served on committees related to Georgia political campaigns. And so some of my comments have to do with my previous career in public service. Some of my comments have to do with my career post public service, but I just want to make sure that everyone recognizes that those comments are absolutely my own and not related to any government agency. So we've had two major issues in the U.S. And they're not dissimilar to what Stephanie shared from Trinidad and Tobago, or David Martin from Quebec, or Oliver from Africa. We've had through the COVID pandemic both misinformation, which is the wrong information, whether it's delivered on purpose or not, and disinformation, which is calculated propaganda. It's information that's intentionally wrong, and it's developed and shared through either informal means or through the media or through public policy with an agenda and trying to move an agenda of the communicators making. So both of those issues have played a big role in all four of our presentations. We've seen in the USA what disinformation and misinformation can do. We just crossed the 1 million mark in terms of deaths from COVID in the United States. And we, of course, have a much greater burden of morbidity in the US from COVID disease as well. We've seen that disconnect happen in both politics and in scientific practice. We've seen the disconnect between politics and scientific practice being a major issue in creating the death burden and the morbidity burden that we've had in the United States. The media, of course, depending on which outlet, has had issues with disinformation, misinformation to varying degrees, depending on how credible the source is. But the ability of spreading messages through social media, through other outlets, and the proliferation of quote unquote news sources in the past couple of decades has really made it difficult to sort through what is trustworthy information and what's not trustworthy information. And a lot of times we've seen political leaders and others that have shared disinformation and misinformation in ways that the public has a very difficult time sorting through and understanding what's credible and what's not. So one problem is that public agencies are quite vulnerable to the political structure by the nature of being a public agency. And of course, it's a very complex situation. If you have leadership at the top with a political agenda, then that makes it very difficult for the public agency to do its job well, regardless of how ethical they might try to do that job. When you have messaging that has to be approved through political channels, then scientific data can be misinterpreted or interpreted intentionally in ways that feed a particular political agenda. And we saw both of those things happen during the COVID pandemic. Also, in a public agency, you're accountable through the executive branch to the president. You're accountable for your budget through the Congress. And so those layers of accountability, while they can be virtuous and helpful and are set up to be so, are problematic when you've got disinformation and misinformation happening throughout the chain. So what's the actual result of those kinds of problems? Well, the New York Times article was published just a couple of days ago on the experiences in Australia versus the experiences in the United States. And the primary difference between the two was this culture of trust. And the culture of trust that was that had been developed over years, not just in the public sector, but in the private sector as well, and including the private sector in much of the work to make sure that the messaging was consistent and was well developed for the populace. And in the United States, we had over 1 million deaths. In Australia, with about 10% of our population, they had 7,500 deaths due to COVID. That's 1/10 if you do the math to put that on a per capita basis. That's 1/10 of the rate that we had in the United States. So many of those trust issues that went well in the Australian system are things that we had challenges with in the US system. So what can we do? What lessons can we learn from this in terms of moving forward? Well, I personally believe NGOs and civil society organizations such as IUHPE play a super important role in helping to develop trust. One thing that is critical, though, is to understand that building that trust at the local level is the key. And I think we heard from David Martin earlier about the first line of community organizers and how important that's been in Quebec. In the United States, the people who are most trusted on health issues are local physicians, are people at the local level like nurses that people have a personal relationship with and have more trust with. As you go from local to state to national levels, you see the levels of perceived trust starting to decline. And so it's important for all of us to think about, in the organizations in which we work and in the public policy arenas in which we work, how can we build the knowledge and skills of local leaders to help them know what to do when these issues arise and when problems of misinformation and disinformation occur. Building the knowledge and skills of local physicians, local experts, local leaders, people that are on school boards who have to make decisions about the schools, people who are on city councils and town councils who have to make decisions about local ordinances, and making sure that we develop professional development and programs that help build that knowledge and skills for those local leaders well in advance of any issue. The other thing that it does is that builds trust in the system when those local leaders are networked across communities, and they know each other and they can communicate with each other and they can share ideas and share lessons learned in ways of working through the politics. We have some NGOs in the United States, such as the American Academy of Pediatrics, American Medical Association, or the American Public Health Association, National Association of County and City Health Officers, et cetera, that all can do and sometimes do local leader training to help those leaders understand these issues early. So, I'll just close by saying that we have a long time saying in the United States that all politics is local. It's very true, and I think we've seen it play out very much in this pandemic. The best way to not only build good public policy and to sustain it is to build that grassroots organization and those local leaders. And I believe that if we do an excellent job of that we'll see down the line that has more and more impact at state and national levels. So thank you for the opportunity to share this information with you, and we'll look forward to taking your questions. Thank you very much.
Thank you very much. Thank you very much, Bill. Well, we have a lot of time left, theoretically. I don't know if we have any questions out there in the world of the chat rooms or anything. Do we have any?
In the chat room right now, I don't have any questions, but that's the time to ask your question for our panelists.
Yes. Okay. Well, let me say that I want to thank all of the presenters for their different approaches and their different positions. I think it's quite interesting to see these different regional approaches to try to deal with the complexity of something like trust. But a lot of things also come up in these presentations. One of the questions that I think is very important is, where do we find trust when this type of area? Some people argue for community organizations very powerfully. Some argue that, well, you've ultimately got to, its locus got to be in the government somehow, or in public health institutions, or in health promotion itself as a piece of public health. Also, the question is certainly brought up in all of this is, how do we build trust? And we see that one of the things in all of the regional presentations, it's been very difficult to figure out how to do that. I think perhaps the example from Zambia was the most clear of an attempt to try to physically build trust by products and promotions. And that seemed to be, to me, quite a clear approach, at least trying to go to the community. The other thing that I think is interesting is, of course, where is health promotion in all of this? And how do you put a focus on health promotion when most of the people who are concerned with something like COVID-19 are not looking at organizations, or whatever you want to call it, institutional programs like health promotion, and they just don't see health promotion as visible to them. It's hard enough even with public health. There was a recent study of who people trust in the medical area with regard to this, and it clearly starts with the most trust. This is in the United States, that the evidence is that the most trust is found in the person's personal physician, which shows that that with regard to trust in relationship to COVID-19, people are going to an individual, and that individual is a trusted person that is their physician, their private practitioner. Now, if in fact they have one, now that brings up another issue that a great many people don't even have such a trusted practitioner to go to. Some of us are lucky and we do, and we can do that, but many people cannot. But one of the things that was most interesting is the more you got to government in general, the less trust there was, and institutions had less and less trust. And when you went to the health institutions in the government, there was even less trust. There was even less trust of NIH and CDC than there was of general governmental institutions, which is quite interesting. In fact, NIH, the National Institutes of Health in the United States, actually ranked on the bottom of this trust scale. So how does something like health promotion fit into this this complex? Where is health promotion functioning in it? So, and where do we build trust if we're health promoters? So that's a really complicated question, it seems to me. The other problematic that I see in this, and that comes up in some of these presentations, but independent of these presentations, is that during the whole pandemic, both I think internationally and certainly in the United States, not only was public health at a not seen very clearly, but the whole problem of COVID-19 was seen as an infectious disease problem. And all of the people who commented on what should be done by people that the press went to and others, they didn't go to people, they didn't go to epidemiologists by and large. They didn't go to public health people. They certainly didn't go to health promoters to get comments. They went to infectious disease physicians. And I found this quite incredible because actually, although it's an infectious disease, the handling of a pandemic is actually a public health problem. It's actually a health promotion problem. It's actually a problem that fits much better with the paradigm of epidemiological work and behavioral sciences work and social science work than it does with anything related to infectious disease. So I found it interesting that in my view, health promotion as an area kind of disappeared during the pandemic, certainly in the United States. I can't speak for Canada or for Africa, parts of Africa or other places, but this certainly was an observation that I had. So I'd be very interested in if any of the panelists would like to comment on that, and if this perception of mine is something they see, or whether they want to expand on what they've already said.
And we begin to have questions, David, on the Slido application. I just sent one question to David Martin, and I will look for the other questions, okay?
Okay.
So, David, maybe you can just read the question that we have and try to answer it while I'm looking for other ones.
Okay.
But you're on mute.
Okay, sorry, I couldn't find a button. Okay, so I'll start with that question. So I was asked by Anika Frasa, sorry, if the groups outside of health promotion and community organizations, so was it about fighting the roots of social inequities, I guess, or rather a functional acknowledgement with the main goal to improve adherence to measures? So the groups outside of health promotion and community organizations, I guess that would be like paragovernmental or private. I talked about some foundations as well. Maybe I can talk a bit about the different roles of those people. So first, for community organizations, they were independent from the public services. So there was the organization, the public health services organizations that was trying to get the measures to be to be better known and better followed by the population, of course, because there was lots of communication, lots of different and sometimes opposing measures that were communicated by the government from one week or 1 month to the other. So it was quite complex for people to understand, and then so to have trust in the people who would bring those measures forward. For the public health departments, we were kind of in between, I would say. As I told you a bit before, so the National Director of Public Health has that double duty of being an employee of the government and being named by the government to be in this position. And at the same time, this person is supposed to be defending the population's health, even against some policies that may be not that healthy. But we have the same position at the regional level as well. We are by law, we need to follow the rules and to follow the measures that are mentioned and recommended by the government. So we need to have them applied, but at the same time, we need to try to maybe put some weight in the balance and try to adapt those measures to the different regional contexts, but also to local contexts. Especially, my job was to try to manage outbreaks, and some of them were, for example, in homeless shelters. So like quarantining in some shelters like that was absolutely impossible. So how can you adapt those measures in a way that will bring safety to those people, that will keep the trust of those people in the measures, but also that will be safe for the rest of the population? So it was always, we were in between a bit, and it was quite hard sometimes to understand how we could do and like keep our values of trying to improve the health of the population, or at least maintain it, and sometimes making sure that some political decisions regarding measures were followed. So yeah, we that's why also I said that maybe we had to rebuild trust within the public health organizations, because sometimes even like COVID-19 was very political in Quebec, and we as public health practitioners also sometimes lost trust in the decision makers. So that needs that will need to be worked on, I guess, for the rest. And for other groups outside health promotion and community organizations, as I said, maybe like the foundations or other actors, well, those ones also were completely independent from the public health services or the health services in themselves. So basically, it was, I think, genuine will to fight the roots of social inequities, even if sometimes their own processes as private institutions, they worsen the social health inequities. So yeah, no, I think it was like genuine will to fight those roots of social inequities in that time of COVID, at least the acute phase of it. So we should build on that also and see maybe those partners that sometimes we are a bit more afraid to work with as real partners, and sometimes they have different interests, but we can have a common interest in improving the population's health. So yeah, that would be my answer to that.
If I could jump into Dr. McQueen mentioned the lower levels of public trust related to CDC and NIH. You know, interestingly enough, pre-pandemic, CDC was the public agency that came up highest on trust year after year after year. And prior to my time at CDC, I spent 8 years on Capitol Hill working with various nonprofits, doing advocacy work on the Hill, and went into hundreds of congressional offices advocating for CDC's budget. And the thing that I most commonly heard from congressional leaders about CDC was that they valued how CDC translated scientific information to the public, and how they were trustworthy about translating that scientific information. I think, the challenge is that it's far easier to tear something down than it is to build something up. And over the first few months of the pandemic, when you had political interference in the scientific messaging, there was quite a bit of damage done to that reputation. So, building trust often happens person to person. It happens, by consistency. It's going to take a lot of consistency and person to person bridge building to rebuild the trust that CDC had, had in the past, and NIH so well. But that was built originally by that person to person work, and by that consistent and correct messaging that had an apolitical and scientific foundation underneath it.
Others want to add into this? I would just add something that at this point, and we do have some more questions too coming up, but it strikes me with public health itself. One of the things that always struck me is that, a lot of people here wanted to blame the political system and the government, and in general, that was certainly something that was very apparent in the American situation in the United States. But also, I would also say that public health itself has a lot of problems. When I said that that when the radio stations and the television stations and all of those people went to the public health agencies and went to the public health institutions to get responses, I said that what they got were epidemiologists, infectious disease people, and so forth. And they did not get the names, they did not get people who deal with communication. They did not get people who deal with transmitting a message to the population. They did not get people who knew how to transmit that message. Those people exist in public health and they exist at CDC. They weren't the ones that people went to because CDC itself and the institutions themselves don't see those people either. So this is a problem of health promotion in general in the context of public health. You know, that an infectious disease person should have said when they were called by Channel 6 or whatever to comment on what's happening locally with COVID-19, should have said, you're talking to the wrong person. You want to talk to the person, the behavioral scientist, who is the communication expert, who knows how to communicate this message to people who watch your program. Not, you don't need a physician at that point. This is a pandemic. This is a communications problem. You're trying to get people to get vaccinations. You're trying to get people to use masks. You're trying to get people to understand distancing. We didn't even come up, of course, even with the right word for distancing. We use social distancing, and as I have written, along with Thomas Abel, we've written about this, that we're really talking about the concept of keeping physically distant from people, not socially distant from people. And those messages are heard by people out there. They hear social distancing. They hear a different message than if they were hearing the words, keep distance between you and someone else. Anyway, that's just a sidebar from my point of view, but I think this is one of the fundamental problems that we have. And so the health promotion isn't on the screen, the TV screen, because those people weren't recognized by the field of public health itself as the ones who should be responding. That's my point. So.
And we have some questions, David. In fact, I just send you in the chat. We have question about accountability. It said that trust is tied with accountability, and without adequate mechanism for accountability, how can we build trust? And when we see public leaders get impunity for anything they can be wrong, what are we to do? And it is said also that public health and health promotion has the bad habit to talk to or to talk for people, as reported by Cindy Blackstock in the conference earlier. So there might be less problem of trust if we were more active in mediating public spaces, like you just said. And we have another remark, comment about how can we do to combat to fight against mis or disinformation, because media is powerful for good and for the bad, you know. How do we harness communication or of any kind for good? So this question is about communication strategies. I don't know if someone wants to react, but I put those questions in our chat.
Well, I would. My response would be to that question about how do we combat misinformation. One of the things is, again, in health promotion, many people have their expertise in how to communicate things properly, how to get people to understand how to analyze propaganda when they see it. You know, and this brings up the whole area of health literacy, which is such a vital part of health promotion. And the idea of having a health literacy approach that functions well, it should have been, you know, a major component of health promotion's response to the issues of communication and misinformation. So that's fundamentally part of our work. And those, again, Yeah.
Health literacy and maybe social capital also, as we just received in the chat.
Oh, yes. Yeah.
You're muted again, David Martin.
Yeah, I'm sorry, I cannot find a button to raise my hand or unmute unless I have this. But if Stephanie or Oliver want to answer, also just unmute yourself if you want. But what we did during COVID also is that we finally reached the 21st century in public health in some aspects in terms of communication. I think that social media is transforming the information quite effectively for the best and for the worst right now. And what we decided to do in our public health regional department was to also go on those social media, and we need to invest. We need to put money in this. We need to have resources, and we need to hire many people, different people who are not the usual people that we hire in public health. So we need to be better communicators, just as Professor McQueen said. And our regional director, she did YouTube videos every week or so to explain basic information on why do we need to distance, why do we need to put the mask, and why is that information different from what it was before. But what we could have done also is to prevent all of those efforts at some point in better communicating the scientific approach. At first, we were saying that wearing the mask was not effective. Well, we just didn't have enough data that would allow us to make a strong statement on wearing the mask and recommending it to different groups. But we didn't say that we didn't have enough data. We were saying that we shouldn't do it because it may have adverse effects. So the communication of risk was not good enough. And that's one of the many reasons why people took so long to wear the mask when it was recommended, because we had the data that we needed. So communicating, I don't think that, I don't know how it is in different countries, but I don't think that here in Quebec we have a very good scientific basic education to understand that doubt is at the center of science, and how do we deal with doubt, and how do we deal with risk, and how do you protect yourself in different ways when you analyze that risk. So that could have been done by better education, basic education on how we, on science and scientific context, scientific concepts, sorry. And that could have been done also in the beginning of the pandemic by better understanding what will come as communications, because we know that there will be very different recommendations that will happen depending on how science evolves. So that could have been done differently as well.
So David Martin, you said something that I was just getting ready to say, which was back over 40 years ago when we only had 3 channels on television. I used to teach high school, and one of the things that I taught in my social science classes was media analysis. And it strikes me that we don't have that type of education in our schools now. And you know, as Oliver mentioned about working with the parent-teacher associations in Africa, working through parent organizations and working with students to help them understand how to analyze media is just, you know, critically important. And those are skills that I don't think we're teaching at all at this point in schools in the United States, at least not consistently or you know, widespread. But I think that it's just super important in today's media culture to help the public have the skills to analyze what they're reading and hearing. The final thing I'd say is that, you know, one reason I've worked in schools for my entire career, more than 20% of the population is in schools on any given school day, between the kids, the adults that teach them, and staff that help them. And, you know, reaching those schools and reaching those parents is a critically important population-based strategy to move the needle on many of these issues.
Yeah, I want to actually add to what you have just actually raised. Yeah, indeed, I think over the years, I think I'm beginning to actually rethink that there is much more that communities, people at the grassroots can actually really offer to health promotion. I think for a long time we have had an expert problem where we actually really thought health issues are only for those who have gone to school to study health sciences, medicine, and all that, nurses to actually deal with. But I think all these societies from time immemorial, we have had our own theories of how we conceptualize health and all that. So I think at the end of the day, some of these pushback we see in terms of like coming out as rumors or mistrust are actually, to me, and that's what I think, but I think feel free to disagree, but I think to me, it's some kind of like a paradigm more, I think, in terms of like how disease is explained and how illness. And I think this is the discourse, it seems, as I've been looking in some of the literature, that I think we really need to move towards more inclusive discourses. And I've seen a very interesting comment, and I'm also trying to touch that. And I think the issues of epistemic justice in health promotion should really be looked at, where we actually really bring in a lot of discourses also from the grassroots, alternative ways of looking at things in terms of like how we actually look at health. And I think once we do that, it's that pushback and that resistance, which actually is sometimes a push back to sort of like the expert problem, which actually has been associated to colonialism and slavery and many other deep stories in Africa, for example. It comes with very, very tough issues. And I think we need to actually really contextualize the mistrust and some of these mistrust or the lack of public trust to some of the deeper stories that have actually really been part of our society, particularly in Africa, where at some point people could not distinguish, for example, medical practice, public health practice from an expert angle with actually colonialism, and people still are suspicious with that. And I think that is something we have to actually really confront and look at a bit more closely.
I'll take on one of the other questions that's over in the question area. It seems to me that there are several questions that sort of relate to each other. And one talked about the credentialing of the profession of health promotion and its role in this. I think there is a role for that because it's the curriculum that one studies in health promotion and what one really needs to know in schools of public health when one gets a degree, a master's in public health or a degree in health promotion. What exactly are they learning? And I think that from this COVID-19 experience, certainly there is a great deal to be learned for how that curriculum should be shaped. That's, to me, a very important thing that we must address in health promotion. We should not have been on the back burner in this whole pandemic globally. In fact, health promotion should have been, I wouldn't say on the front burner because, you know, health promotion is a long ways from the front burner everywhere, but it shouldn't be on the little back burner. It should be there. And as I said before, it should be seen, and this has to do with the workforce of health promotion and working among partners collaboratively within the field of public health so that people understand what the function of health promotion is. And if they see that there are things that are available in the field of health promotion that can aid in building trust and working with communities and dealing with things like scientific uncertainty. I mean, that's one of the things that really came up to me in this COVID thing is that the public has a difficult problem understanding something that is very complex if it's produced or presented, I should say, to them as something simple. I think this was a fundamental thing that happened, that people, it happened with the masks, where one day they said, oh, you don't need masks. And they say, okay, you should have masks. The message that should have been out there should have been that this is a complex event. The pandemic is complex. We're working on it. We have more information as we gain it. At this point, we don't think you need to wear a mask. Now, this may change. So be ready, it may change, it may not change. But most people are used to having things presented to them where the final answer is not clear. But one of the problems in this pandemic, it seemed to be, as many people said, this is the answer. And of course, the politicians in the United States made this particularly problematic because they said they know how to do it. And transferred the whole issue away from a public health issue to a political issue. And that is something that we should have been ready for, in my opinion, as health promoters and in public health. So that's my final comment of the day. Others may have some final comments because I think we're just about out of time. I see we have 1 minute and we have 59 seconds left before the great electronic situation shuts down, I guess. So any final comments from any of our presenters they'd like to make?
Maybe we can thank the audience. You know, it was fine to have them with us today, even if I can't see them. But I would like to say thank you to everyone who looked at this session.
Of course, I'm going to say that also. I would like to thank all of our presenters, and I'd certainly like to thank, this went more smoothly than I had anticipated, given that we were all electronic, but I would like to thank everybody who participated, both on screen and off screen in the audience and in the recordings to come. So thank you very much for everything.